Oh, I didn't. Thank you. Yeah, no, I like the combos. I learned more that way.
I'll use this.
Hello. Hello.
Right. Oh, they did. Yeah. They did. Yeah.
There you go. So, are we all set up, ready to go? Perfect. We have the sound. You're great.
Okay, welcome everybody to our second breakout session. Excited to see you all here today. So our second speaker is Dr. Joel Bush. Just a little bit of information about him. He began his interest in addiction treatment during his United States Army career as a physician resident training in family medicine. Since then, his passion for treating patients with addiction has continued to grow as he completed a fellowship in addiction medicine at the University of Maryland in Baltimore, and then began treating soldiers and their family members who suffer from addiction. He completed his 15 years of active duty service in 2018 and transitioned to the Utah Army National Guard, where he now reviews positive urine drug tests for all soldiers in the state of Utah as part of their substance use prevention effort. Currently, he owns a private addiction medicine practice in American Fork and works with other large and small addiction treatment programs. He enjoys direct relationships with each of his patients, helping those who struggle with heroin or other opiates, cocaine, alcohol, marijuana, pornography, gaming, binge eating, or any addiction. So, we would really like to welcome Dr. Bush.
Thank you guys, thanks for coming. So hopefully I will go through this presentation quick enough that there will be plenty of time in case anybody has any questions. So one thing that a lot of people don't understand about the opiate epidemic is that it didn't start recently. It's been going on for a long time. We can trace the roots of the US opiate epidemic all the way back to the mid-1800s. So there's a lot that our country, a lot of baggage we have when we're talking about opiate use. This problem has been going for a long time throughout history, throughout the world, and has been noted in early writings as early on as 3000 before Christ. Middle Ages and Renaissance records often discuss opium use, and really what I'm focusing on in this slide is these three events here. 1805 is when morphine was isolated. We learned how to make morphine. Okay, 1850 was the invention of the hypodermic syringe, and then in the 1860s when we had the Civil War in our country. And that's really where the opiate epidemic started, because of those three things: morphine, the syringe, and a lot of battlefield trauma that we found we could treat really effectively with morphine and a syringe. That created a lot of people who needed opiates because they were given it frequently for their chronic pain issues. Okay, in 1898, Bayer, the drug company, marketed heroin. Okay, this was an anti-cough medicine that was marketed, and it worked really, really, really well, and it was very reinforcing. But whenever you hear heroin, that is a trade name of a medication that was marketed. So just keep that in mind. I don't put all these things on the slide to talk about each one of them, but just kind of for you to see a little bit of what was going on in our country. Okay, so one thing that I talk about a lot with my students and residents is the 1914 Harrison Act, because after the Civil War in the late 1860s and what culminated with a lot of heroin addicts after heroin was produced, the country was faced with this dilemma on what to do with all these people who could just go get heroin from the apothecary down the street because there was no prescription needed for it. You could just buy it, okay? And it was deemed that you had to have a prescription, but then when you had that prescription given very freely, what do you do? And so the president at the time, President Harrison, decided we're going to kind of tap down. We're going to get a little bit strict about all these doctors that are prescribing opiates for people. A lot of those doctors who are prescribing opiates meant well, because they saw these people were addicts, and what they needed was somebody to regulate their opiate use in order to manage their lives. And then there were some unscrupulous doctors who were doing a lot of prescriptions just for monetary gain. So Harrison passed the Narcotic Act of 1914, which said a physician may not prescribe an opiate to a known opiate addict, or that physician will go to jail. So that was ratified a few years later, and we kind of got scared as physicians in our country to prescribe opiates because we were afraid, because a lot of doctors did go to jail. Some of them should have gone to jail. Some of them probably were well-meaning. But we kind of got scared, so we stopped prescribing opiates, and that is when heroin in the black market started really growing. So we kind of indirectly created an underground of opiates that were because we already now had the demand after the Civil War. So now there's a demand, and now we cut off the legitimate quote-unquote supply. Now we're going to get an underground, okay? All the while, interestingly, you can see some of these other events that are occurring that kind of help to either spur or try to address the opiate epidemic. The FDA was created in the 30s to try to deal with how do we manage like controlled substances, or the idea of having like certain standards for prescriptions. And then the Vietnam War happened. The Vietnam War is very interesting. If you ever want to go down a rabbit hole of learning about opiates and opiate addiction in our country, the Vietnam War was a big deal. There were up to 44% of the tests that came back from the US soldiers in Vietnam were positive for heroin. It was a big deal, okay? So in that they realized, okay, we must not be addressing this epidemic like we should, so we need to start doing something different. And that's when the methadone clinics first started, was in the 60s. In 1970s, when the Controlled Substance Act was first passed, which puts substances into their controlled tiers, class 1, class 2, and so forth, or scheduled narcotics. And in 73 was when the DEA was started. From the 70s through the 80s, because we addressed the Vietnam War and because we had these controlled substances in their schedules, and we had kind of addressed a lot of the illicit use, we see this sort of era of opiophobia in prescribing, where doctors wouldn't prescribe opiates unless it was their only opportunity, or their last opportunity, their only option. And so you had the sentiment in the 70s through the 80s was very much anti-opiate treatment, anti-opiates for pain. And so there was illicit opiate use, but it wasn't as big as it had been. And then there wasn't a lot of prescribing at this time. So how did we get from what looked like we were on the way to figure this out to where we are today? Okay, what happened, honestly, is right here. Okay? So in the mid-90s, the chronic pain world started to kind of grow in its advertisement and its pursuing treatments. And all along the way, we had a lot of opiates get approved by the FDA for use. But we kind of were still scared of using them. So when Purdue Pharma created OxyContin in 1995, they spent a lot of money on marketing that drug. Okay? Who's familiar with the Joint Commission? Who's ever heard of the Joint Commission before? Okay. So back in the mid-90s, the Joint Commission and Purdue Pharma actually entered an arrangement that was not known, sort of a backdoor deal, that we would create the need for more opiate prescriptions, and then Purdue Pharma would come in and rescue us with the supply of what we needed. So the Joint Commission required every healthcare facility that was accredited to ask about pain at every single visit. They called it the fifth vital sign. Have you ever heard that? Maybe. It was a campaign to try to help us talk about pain with our patients, to try to address pain management. But it was also with an ulterior motive and an agenda to sell OxyContin. OxyContin was touted as a non-abusable substance, non-addictive. Who in this room believes that? Good, because it was not true, right? So they marketed it very, very heavily, and they marketed it to everyone. They marketed it to the patient, to the patient's family, and to the healthcare world as well. And they were very successful. And so that's when the tide started to turn. And that's when we started to flood the market with OxyContin and Miscontin. And that is really what stimulated the beginning of the opiate epidemic that we're still battling today. Okay, that part of the epidemic. So you can see that it started early, Civil War. We kind of got it sort of under control about 100 years later, and then now it's just kind of taken off. Okay. Interestingly, this last slide right here is not a good thing, because during the era of COVID, we've seen overdose rates rise significantly. 38% last year. That's huge. It was actually starting to come down up until COVID. So let's just review the criteria for opiate use disorder. I know a lot of you are familiar with this, but some of you may not be as familiar. The DSM-4 used to say abuse or dependence, and now the DSM-5 says, substance use disorder, mild, moderate, or severe. And so someone who has opioid use disorder has difficulty controlling their use. It impairs them in their relationships. It impairs their ability to function. And it also gives them tolerance and withdrawal. All you need is 2 of these criteria to have an opiate use disorder. 2 of them. That's it. They cannot be just these 2, however. If you just have tolerance and withdrawal, that does not count. You have to have at least one of the others. 4 or 5 is mild, and then 6 and above is severe. The vast majority of patients that I see are in the severe category. Just look at this graph. Have we got a handle on this opiate epidemic yet? Not yet. Okay. So the American Society of Addiction Medicine National Practice Group released a statement last year saying the combination of pharmacotherapy and psychosocial treatments tailored to individuals' needs is the recommended standard of care. One of the things we've been battling in the substance use treatment community is the anti-medication sentiment that is out there. It's strong, and we could spend the entire day, actually, this whole conference just talking about that one topic. But there are a lot of people out there who, for a lot of good or not so great reasons, believe that you should not give a medication to someone to treat them for their opiate use. Because if you are giving them an opiate or opiate class, you're just trading one addiction for another. Okay? That's a tough argument to get over for a lot of people. When I first came here, so after I got out of the active service, I came here to open up a practice, and I found that that sentiment is alive and well in Utah County. Very alive and well. In the treatment community, in the substance use treatment community. I went to a lot of treatment centers, residential treatment centers, and sometimes the first question that they would ask me is how I feel about Suboxone. Which, that caught me off guard, because I thought, that would be like asking a diabetic specialist how he feels about insulin. It's a medication that I use sometimes. I'm not really sure what the question is aiming at. And then they would clarify, well, we don't do that here. We don't do that in our treatment center. We don't do Suboxone. Because it's just trading one addiction for another. And I had to kind of do a double take. Really? So, part of what we are trying to do in the addiction treatment world is to try to help educate people about why that idea about treatment is harmful to patients, and why it helps this epidemic continue to grow. So I'm not interested in you reading all of these, but this is just to kind of give an example of how many good, validated articles and studies that are out there that help to refute that notion by very reputable organizations that have done their diligence in studying and researching these medications and pointing out that they are the standard of care because they save lives and they help people get into recovery. There are 3 medications that we have that are FDA approved for opiate use disorder. Only 3. So yes, there's a large body of evidence. There's not a large body of medicine that we can use. Methadone is our first medication we're going to talk about today because it was the first medication that was invented for opiate use disorder back in the 60s. It is the standard of care, or has been for a very long time. Methadone's been around a long time. There's a lot of tradition. Okay? It's a full opiate agonist. And what that means is that it activates the opiate receptor completely and fully in every way, just like any other opiate would. Heroin, codeine, morphine, dilaudid, fentanyl, all those are full agonists. And methadone is a full agonist. Okay? So what does that mean? What does full agonist do? Full agonist completely gives you the full opiate effect. That means there's some euphoria there because the mu receptor in the body gives you euphoria when it's activated, which is one of the reasons why these opiate medications are so reinforcing, because they make you feel good. Because that mu opiate releases dopamine in the brain, and that gives you a feeling of pleasure. So one of the things about the full agonists is that they are euphorogenic, and therefore they're abusable and addictive. Most mu opiate agonists, or drugs that act on the mu receptor, they do not have a ceiling effect. A ceiling effect is where, for example, if I take 1 milligram, it will do a certain thing, and then if I take 2 milligrams, it will double it, and if I take 4 milligrams, it will continue to double it forever. Until, with opiates, eventually it will suppress my ability to breathe, and I will die. So there's no real ceiling effect to how high you can go on a full agonist. With methadone, the reason why methadone was invented for this is because most opiates you have to take multiple times a day in order to have them continue to be active in the body. Methadone has a 72-hour half-life, which means you can take it only once a day, and it still is going to give you full coverage of opiate feeling all day long and into the next day. So that way people can come in once a day and get a clinic dose, and then they can go about their day, okay? In order to dispense methadone for addiction, for opiate addiction, you have to do it in what's called an OTP, or an opiate treatment program. These are programs that are certified and licensed by the state to dispense methadone. You cannot dispense methadone out of your personal, private practice. It's not something you can do. So you can't do it in an outpatient setting. It has to be done through that program specifically. So imagine you're an opiate addict and you're out on the street using heroin and you want to get better, and you just decide to use methadone to do it. You have to come into the methadone clinic every single day to get your dose. And they dispense it into a little cup. It's a liquid. And you have to drink it in front of a window, in front of a nurse, every single day. Okay? Is that better than going out and shooting up heroin in the street? Yes, it is. But is it conducive to a normal lifestyle? No. Who can go to the clinic every single day before work? So methadone clinics are open very early hours. They're usually open like 4 a.m. to 9 a.m. or something like that. Maybe 5 a.m. to 11 a.m. So people can go in the morning, they can get their methadone dose, and they can go to work. The most common side effects from methadone are nausea, constipation, drowsiness, and some decreased sexual function. Okay? Methadone also is prescribed for chronic pain. A lot of people don't understand the difference. I can prescribe methadone in a pill form if I'm using it for pain, not for addiction. Okay? If I'm using it for addiction, it has to be done this way. If I'm a pain clinic and I'm saying, hey, for your pain, no, you don't have an addiction. I'm not saying you have an opiate addiction. I'm saying that you just have pain issues. I can prescribe you pills of methadone. You can go to the pharmacy and pick it up. And then you can have a big bottle of methadone that you take home. And then you can take it whenever you decide, right? So that kind of prescribing practice is what got us into this problem. But it is still FDA approved for chronic pain, just so you know. We're going to spend a little bit more time talking about buprenorphine. So buprenorphine is the active component in Suboxone, Subzolve, Subutex, Belbuca, Sublocade, Probuphine. All of those medications are buprenorphine. Buprenorphine is very interesting because buprenorphine is a partial agonist at the opiate receptor. It's one of the only partial opiates we know of. Okay? So that means it acts differently at the receptor. Partial agonist. So that's the difference between like a light switch that you turn on and off and a dimmer switch that you turn on a little bit, or however much you decide. And so all other opiates you can think of, fentanyl, Dilaudid, Lortab, all of those, they either turn the receptor all the way on or it's not turned off, or it's not turned on at all. But buprenorphine switches it on just a little bit, okay? That leads to some good pain control from buprenorphine, but it also leads to a lower number of side effects because it's only activating that mu receptor part of the way. It also has a ceiling effect, okay? So ceiling effect means that you can take buprenorphine at a certain dose and you can keep increasing your dose, but at a certain level, if you take a certain amount of buprenorphine, it won't do anything more than what the previous dose will do. You can keep adding more and more and nothing extra will happen. So you reach that ceiling, okay, which is really helpful. The ceiling effect of buprenorphine is about 16 milligrams per day. So that's kind of a low dose to have a ceiling. So that's kind of unusual, but it's part of the reason why we like to use it for this disorder. And I'll get into talking about that a little bit more down here. Most opiates that touch on the mu receptor, the one that's responsible for pain control and for euphoria, also touch on another receptor that causes some like nausea and sort of like a blah feeling. I don't know. I mean, a lot of people have had that experience when they've gone in and had a prescription for opiates and they just say, oh, I don't like the way it makes me feel. It just makes me feel like I don't like that feeling. We call that a dysphoria, okay? Buprenorphine actually reverses that effect because it it reverses the effect at the kappa receptor, so it gives you sort of just an overall well-being sort of feeling, not like a euphoria, but just like I feel normal, like a normal feeling, which is nice. Kind of like similar to what an antidepressant would give you, okay? All right, one of the reasons why buprenorphine was kind of kept at arm's length for a lot of prescribers for many, many years is because of this next part of what it does. It has a very high affinity for the opiate receptor. An affinity for the opiate receptor you want to think about as like a magnetism. How strongly does it get attracted by that receptor? Or how strongly does it bind in there? And it's got a very, very high affinity, which means that it attaches to the receptor very, very quickly and strongly. Which means that if there's any other opiate in that receptor, it will actually go in there and kick out that other opiate and stick it in there really tight. And so what will happen if you give buprenorphine to someone who has any opiates in their body is it will send them into a precipitated withdrawal, which is horrible, and they will not like you at all. And they will not ever want to take this medication again. Because they'll say, I took it and I'm allergic to that medication. Or I took it and it put me in a withdrawal, I will never touch that again. Right? And so you have to be aware of this when you're patient. And most people on the street who are opiate users are actually very aware of this themselves. They will learn on the street. Take this when you're in withdrawal, but do not take it until you're in withdrawal. Because if you take it before, it'll put you into withdrawal. And so that's something that a lot of providers would say, I'm not prescribing this medication because I'm not sure when I'm supposed to give it to someone, and I don't want to put them into withdrawal. And so that's part of what we need to learn about buprenorphine. You need to give it first. Then if you give an opiate, the opiate will do nothing. But if you have opiates in your system, you have to wait until the opiates leave, then you can get buprenorphine. And how long do you need to wait? It depends on the opiate. If opiates last for 24 hours, you need to wait for over 24 hours. If they last for 5 hours, you don't need to wait as long. A good rule of thumb is to say 24 hours is a good rule for your last dose of any opiate. And especially with heroin, now they're mixing heroin with a lot of things, and you don't know what's in that heroin. So it's good to say, just wait for 24 hours, and then you can start. On the other side, like I said before, if you give buprenorphine first, and then they use opiates, they don't feel those opiates. Because that affinity for the receptor, it goes in there and it just sticks in so tight that any other opiate's not going to do anything. Which is why it makes it a very good medication for treatment of opiate use disorder. So if I take Suboxone today, and then later tonight my friend is like, hey, let's go use heroin, and I think, okay, fine, I will. Then I go and I use heroin, guess what I'm going to feel? Nothing. So it helps to reinforce that idea that they don't need it. They don't need it. Okay, it has a very long duration in the body, so it lasts about 32 hours. Which means, again, you can dose it each day. You don't have to dose it multiple times a day. And then lastly, it's got high receptor occupancy. What that basically means is that it fills the receptors up fast. At 2 milligrams, you get at least a quarter of the receptors in the body full already. That's crazy high. That's amazing. And at 4 milligrams, you're already like 3/4. And then at 16 milligrams, you get up to 95% of your receptors filled. Which is why we don't tend to go over 16 milligram doses for patients that are on Suboxone. Because I can double it to 32 milligrams and I am only getting maybe 1 or 2 percentage difference. Most of the patients will know this. They'll say, if I take 16 milligrams or 24, I feel about the same. So what do you think is going to happen if I'm a prescriber and you come to me and I say, how much Suboxone were you on? And you're like, I was on 28, or I was on 32. I need 32 milligrams. What do you think I'm going to say to you? I would say, that's interesting. What happens if the patient is honest and I ask them, well, what were you doing with all 32 of those milligrams? Were you taking them all? If they're honest, what would they say? No. I would usually take about half of that, and then I would give the other half to my spouse, my friend, or I'd sell it, or I'd save it for myself later, because when they run out of their buprenorphine, what's going to happen? They'll have withdrawal, so if they save some of their buprenorphine for later, it will come in handy later on. And if these guys are not the most reliable people at coming to their appointments, and they miss an appointment, ask me how often that happens, right? Then they'll have some stash for later, which is actually kind of a logical thing to think, even though we don't like to tell them to do that, and we don't want them to do that. But you can see how that would be logical. Well, I'd like to have some in case I go to withdrawal. So the high receptor occupancy, the affinity, and the partial agonist qualities, these are why we use buprenorphine so much. It doesn't tend to create really high sense of dopamine or euphoria. It doesn't tend to be as reinforcing. It doesn't tend to get out of their system as quickly, and it helps to block those receptors so other opiates don't work, okay? So that's why buprenorphine is so valuable in the treatment of opiate use disorder. And as I said before, it comes in a lot of different forms. It used to only come in injectable form many years ago. But so the problem with outpatient uses of buprenorphine is that you can't swallow a pill of buprenorphine. It does not work. It doesn't absorb through the GI system. So like almost all their medications we give, you can't swallow it and have it work. You have to find another way to deliver this to the patient. So that's why Suboxone is a sublingual tablet. It has to go under the tongue and dissolve so that the medication goes straight through the lining of the mouth into the bloodstream. Because if you swallow it, you won't get anything, okay? It comes in, the most famous Suboxone is the one that's most well known, and that one has both buprenorphine and it has naloxone in it. Naloxone is basically Narcan. It's what you give people when they overdose. You shoot it and then it sends them into withdrawal. A lot of people don't understand why Suboxone has naloxone in there. The reason why it's in there is to discourage people from shooting their Suboxone into their veins, because the naloxone will actually sort of diminish how it feels, how like the high you can get. Can you get as high on Suboxone as you can get on other opiates if you inject it? No, it doesn't come close because it's only partially turning on that light switch, right? But in a pinch, if you were an addict and you injected just plain buprenorphine, you could feel a little bit of a high, okay? And if you have naloxone in there, it's going to dampen that ability, which is why they put it in there. It's just to discourage people from injecting it. It is not, the naloxone in there is not going to be doing anything at all unless they inject it. Because naloxone is not orally bioavailable, and it is also not bioavailable under the tongue. So the naloxone in there is mostly not even doing anything, except tasting awful. If you ask any of your patients if Suboxone tastes good, and they will tell you it tastes awful. And most of that is because of the naloxone. It just does not taste good. But it also is primarily there to discourage injection use. That is the only reason it's there. So when people say, I'm allergic to Suboxone, so I need Subutex, what might you be thinking they're really saying to you? That they like to inject, and they like it better without the naloxone in it. Okay, that might be what they're actually saying to you. It might not be, but that's always one thing that I have to keep in mind when someone says, I can only take Subutex. Okay, so this is just a smattering of some of the different products that buprenorphine that we've developed with buprenorphine. And right down here is like a picture of what it looks like when you give someone a Sublocade injection. We'll talk about Sublocade a little bit more. In order to treat people for opiate addiction with Suboxone in an outpatient setting, you have to have currently an X number on your license, on your DEA license to prescribe controlled substances. And this is a waiver to the Harrison Narcotic Act. That's what that number means. It means, hey, yes, we still have this law in place that was passed in 1914 that says if you give an opiate to a known opiate addict, you go to jail. Except if you have this number, that means that you can use buprenorphine to do treatment for opiate addiction in an outpatient clinic. That's what that X number means. So if you've ever heard anyone say, I need to have an X number or a waiver, that's what they're talking about. So we're going to talk about Sublocade for a second, because at Wasatch, when we treat people for opiate use disorder with buprenorphine, we transition everyone to Sublocade. Suboxone is newer. It has been developed more recently. I think it was FDA approved in 2018. So it's kind of a new kid on the block as far as medications go. But it has got a lot of really good characteristics to it that make it really helpful for patients. And that's what we're going to talk about. So it provides that blockade that we talked about, where if you get this medication in your system first, then no other opiates function. That's really the most important quality of this medication. Can I get this person who likes to use opiates to not be able to do that? Yes, and that's what Suboxone will do. Okay, it's an injection that goes under the skin in the abdominal area. Once you inject it, it deposits it kind of hardens into a little pellet of medication that will be there for months. Sometimes it won't be completely used up for 6 months. So their dose won't be the same for that 6 months, but they will have the medication still in their system at some level for at least 3 months. What this means is that it kind of takes that whole compliance question and it settles that matter. Because as prescribers, that's one of the biggest challenges we have today is compliance. So when you're in the business of prescribing something to someone and saying, I need you to take this every day, and how many of us are perfect at taking our medications exactly as we're supposed to? It's not always easy. And for this population, they have many other reasons why they might not take it every day. And with Suboxone, it could be, hey, I'm planning on having a good time this weekend. I'm not going to take my Suboxone, or it's going to prevent me from doing that. So, or it could just be, hey, I ran out of my medications. Suboxone prevents them from doing that. It prevents them from sharing their medication, selling their medication, stockpiling their medication for later, stopping their medication on their own, changing their own dose. Prevents all that stuff. The first month and a half to 2 months, they are guaranteed to be on the same dose. All right? And so that's one of the reasons why we like it. And I know in the mental health world, we have a lot of medications that we like to use injectable depots because it helps to keep our patients at the right dose for a long enough period of time to get them to where they need to be mentally. And this kind of has that same principle. So you give it every month at first. It will be every month like clockwork. You come in every 3 to 4 weeks and get that injection. And then after they've had about 5, 6 injections, you can start spreading out their injections a little more because it doesn't build up to the point where they're going to have the same dose now for 2 months. So they can start spreading it out to every 6 weeks, up to every 8 weeks for every injection. Now, why would they want to spread out those injections? They hurt. They hurt a lot. And having done hundreds of these and watching patients' facial expressions while I'm injecting this medication, they are very painful injections for a lot of people. Some patients, for whatever reason, just say they don't hurt. But I'd say like 75% of the patients that I do give this injection to will just say that it burns like crazy. They describe it as a miss, like using meth and missing a vein. It burns really bad. And for those of us who don't know what that means, imagine having a hornet under your skin stinging you repeatedly for about 2 minutes. That's kind of how they describe it to you. So it's kind of painful, which is why they don't want to get the injection as often as every month if they don't have to. But because of how long it acts and the protection it is against future episodes of opiate use and future episodes, especially of opiate overdose. These medications are expensive. This medication costs $1,760 for one injection, which a lot of times you tell people that and they think, that's ridiculous. How much does it cost if someone ends up overdosing, getting an ambulance call to take them to the ER, and then having an overnight ICU stay on a ventilator? Does anyone have any idea? This is cheap. This is cheap compared to that. So it can prevent large costs like another stint of 30 days or 60 days of rehab, or hospital admissions and overdose deaths and things like that. So it is expensive, but there's a benefit to doing that expensive. Okay. The most common side effects for buprenorphine are going to be nausea, Not as much as with the other opiates. Constipation, not as much as with the other opiates, and a little bit of drowsiness. So you just got to work their dose up to 16 milligrams carefully enough that you're not making them sleepy. That's really the key there. And there are some people who are on buprenorphine that are not opiate addicts. So Suboxone has that stigma, right? And everybody who's heard Suboxone and what it's for, they're more commonly going to think of opiate addiction. But it actually is not just for opiates or opiate addiction. It can be used for chronic pain as well. And I've seen patients that have never ever abused their opiates, they're on buprenorphine. And if we go back to why buprenorphine is a good choice and it has lower side effects and it lasts longer and it's less abusable, then you kind of almost say, why wouldn't you give that first for chronic pain instead of giving some of these stronger, more abusable or addictive substances? Okay? So even if they don't have an opiate addiction diagnosis, that doesn't rule out using buprenorphine. It just means that buprenorphine sometimes isn't thought of. Sadly, sometimes isn't thought of when you're not treating addiction. It should be. Okay, so it can be used for chronic pain as well.
Dr. Bush?
Yes?
So then if you're in the hospital and you're getting opioids, I would say for kidney stones,
Mhm.
like dealt with, why would they not, can you ask her, can you say, can I have this instead?
So for acute pain, so acute pain is like the pain that you get in an emergency, like for a kidney stone or for an appendectomy or for a car accident, or you get a laceration. Buprenorphine may not be the perfect thing to use for that acute setting because it's so long acting, but for chronic pain. So for people who are like, my back has been killing me for 10 years and it's making it hard for me to do my job. If I met that person in my clinic and they're like, oh my gosh, my back's been killing me, I've tried physical therapy, I've tried all of these other, non-medication ways of dealing with my pain, I don't want to have surgery, what's my next thing? Should I start taking pain pills for this? Then that's when you might say, hey, maybe we should think of buprenorphine first because it's got so much more of a lower safety, or a higher safety, and lower side effects. But in an acute setting, that's what regular opiates are for. And we shouldn't be afraid to use them in that setting, right? We shouldn't be afraid to take an opiate for a kidney stone or an acute appendicitis or for surgery or things like that. That's what they're meant for. We shouldn't be afraid of that. But we should not be going to opiates as a first choice in chronic pain. And I can't tell you how many patients I've seen for pain. How many of them that are addicts on opiates started out with a pain medicine for something that probably shouldn't have been pain medicine, right? That's my shoulder was bothering me, and instead of sending me to physical therapy or doing whatever, they just gave me a bunch of Percocet. Then I liked them. I liked them a lot. So I came back and said, I still need those. And then 3 years later, I'm on heroin IV. I lost my kids. I lost my job. What if instead of giving them that, we had said, well, let's think of some other options. But for acute pain, I hope that answers your question. If you're in the hospital, you don't need like, give me this Suboxone because it's safer. If you're only going to be taking a few doses, then it probably isn't going to be. If you're going to be staying on it, then yes. Does that answer your question? Okay. Okay, the third medication we have to treat opioid use disorder is Naltrexone. Naltrexone is not an opiate. Naltrexone is the opposite of an opiate. It is an opiate antagonist. It goes to that same receptor that we talked about before that turns the light switch on or off, and it prevents that receptor from being touched. Kind of like that lock and key model. If the keyhole is the receptor and the key is the medication, it's like squirting super glue into the keyhole so no key can get in there. That's what Naltrexone does. It prevents opiates from having any effect on you. Now, if there are opiates in the receptor and you squirt them and you end up pulling the key out, then people are going to have precipitated withdrawal, just like we talked about before. So you can't give Naltrexone until people have had no opiates in their system for a long time, okay? It comes in two forms. It's a pill form called Revia, or just generic Naltrexone that you can take, which is also used for alcohol use disorder. And you have to take that pill every single day. And it also comes in a shot. Who's heard of Vivitrol? Okay, so Vivitrol is Naltrexone depot that lasts for about 30 plus days. Okay? So obviously that would mean that they are going to be more compliant for that 30 days because they have no choice. Because you shot them right here, and now they are going to have Naltrexone in their system for 30 days. But will they come back? That's the question. So yes, you've got them for that 30 days, but they may not come back. Naltrexone, unfortunately, is not reinforcing in any way. It does not give them a normal feeling. It does not help them feel better in any way. And so many of these patients will not even want to get on it. And if they do, they often will not come back for the second dose. Opiate addiction is complex. When you go through opiate addiction and then you get off your opiates, your brain has a lot of dysregulation, and the chemicals are all out of whack. It's going to take months and months and months for that to kind of get restored to anywhere that makes the patient feel like they're normal. Now, if you give them Vivitrol, they have no way of feeling normal for those months. They are forced to feel abnormal. They are forced to feel empty. And so many patients that do this do fine, but I would say that out of the 3 medications, this is the most difficult one to keep people on, because for that first year, their brain is just doing everything it can to come back to normal, but it is a very disquieting way of living your life when you feel like you can't get any kind of normal feeling, and it's very difficult for them. So that is one of the reasons why this medication is not as successful. If they do have Naltrexone injection, they need to be wearing a bracelet. So if you ever meet someone who's on Vivitrol and you are their therapist, or you are their case manager, or you're involved in their care anyway, then you should be checking to see if they have a medical alert bracelet on. Because if they go to a hospital and they've had an accident and they're on Naltrexone, watch out. And the people at the hospital don't know they're on Naltrexone, those people are going to be in a lot of pain, and there will be no relief for their pain, because they will just try to give them the standard doses of opiates and it won't work. So that's why those alert bracelets are so important. So if you see someone on Vivitrol, it's good to just check. Hey, do they have that bracelet? Or they have a dog tag or something like that. Okay. So Naltrexone is not reinforcing, so there's no street value for it. It's not abusable. You don't withdraw from it or anything like that. So it does have some positives, but a lot of people, it's actually more effective to give this for alcohol use disorder, because those people, they don't have that same empty feeling that the opiate addicts have. One thing to keep in mind about Vivitrol is that if you give a patient Vivitrol and they are on opiate addiction, and then they don't come back for their second Vivitrol and they relapse, their risk of overdose is very, very high. Because what it does is it resets their body's tolerance to opiates back to kind of like the original. So if they've been using heroin for 20 years or 10 years, they have a very high tolerance for opiates. And then you give them one Vivitrol shot and it takes them back to their tolerance before they even tried heroin. They know that. So they're going to go try to take a small amount of heroin, but they still might way overshoot and kill themselves. So Vivitrol, you have to be aware of that. Vivitrol does increase the rate of overdose deaths if people don't come back and get their next treatment. Most common side effects are nausea, vomiting, diarrhea, headache, and precipitated withdrawal if you give it too soon. And then it is something you can use for alcohol use disorder. It's actually a really good medication for alcohol use disorder. Naltrexone at very, very low doses is sometimes helpful for chronic pain. Not hugely helpful, but sometimes a little bit helpful. And then of course, Naltrexone is also one of the main treatments we give for people who have like behavioral addictions like pornography use, gambling, internet use, binge eating disorder type addictions, that type of thing. So these are some of my sources. And so we've gone over the opiate addiction medications, those 3 medications we talked about, what questions do you guys have about opiate addiction or opiate addiction medications?
So I guess my first question is, what about those clients that come in that have maybe been off opiates for 2 to 3 months, but they're starting to get cravings again? You know, they're kind of feeling that low that you were talking about. Do you go to Suboxone for those patients, or do you go more the Vivitrol route and try and help them with antidepressants and some of those other things to kind of get them through that low?
Yes. It actually is really, really important to sit down and have a conversation with these patients and ask them what they would like to do. Because as we all know, with this population, you need some sort of cooperation and buy-in. They're not going to do well if you just force them down a pathway that they don't want to go. So I talked to them about the 3 medications. I sat down and I said, there's Methadone, there's Naltrexone, there's Suboxone, or Buprenorphine. And almost all of them have had some experience with one or all of those medications in the past. So what I try to do is I try to explain to them the benefits of each one, maybe the drawbacks of each one, and then I say, what would you like to do? And then if they have a legitimate reason why they would like to do one thing, then we go down that pathway. There are lots of reasons. If they have alcohol use disorder and opiate use disorder, I will nudge them toward Vivitrol, because I will say, hey, look, this works. This is the only medication out of the 3 that works for both alcohol and opiates. This is what we should be using. If they have a lot of chronic pain issues, I'll try to maybe nudge them toward buprenorphine. If they tried buprenorphine and naltrexone and both of those things have failed miserably, then maybe I'll suggest methadone. I use methadone only as a last option, though. I think methadone is probably eventually going to kind of go completely out of favor. I think there will probably always be some sort of demand for it on a small scale, but I think methadone is kind of going eventually the way of the dinosaur when it comes to opiate use and treatment. Because buprenorphine is just so much better in almost every way. But so usually it comes down to those 2 choices. Do you want naltrexone or buprenorphine? And I'll usually try to see like where the patient is. And like, well, I was on Suboxone for a long time and it worked really well for me. I tried Vivitrol and I hated it. Well, that's a pretty simple, okay, let's talk about buprenorphine again. Sometimes they want Vivitrol really bad and I say, okay, we can do Vivitrol. And then it's difficult to get that 10 to 15 days off of all their opioids. And we can never get them on Vivitrol. So it's like, well, maybe we should think of another option. Because I only need 24 hours off of opiates to go for buprenorphine. So, does that answer your question?
Yeah.
It's up to the patient's circumstances. I certainly have some patients, just to sort of caveat on there, that will say, I don't want any of those. I don't want any of those. I just want to get off of everything, and because I just don't want to be on anything. And those patients do not do well. And I will support their plan if that's where they want to go. If they want to take option number 4 and say, I don't want to be on anything, I will taper them with buprenorphine. And then I will say, that's your choice. I don't think that this is the best choice, but I will support you in that choice. Then most of those people relapse because opiate use disorder, the data is out there. If you're not on one of those 3 medications, it's like 90% relapse. So it's pretty high. And I'd rather have them be on a medication and not relapse and overdose and die. So, other questions?
Yeah, I've used naltrexone a fair amount for different behavioral addictions with some success, not as much as I had hoped. I don't get any tricks with that.
So, what I have found is that people need higher doses often with those kind of addictions, like up to 200 milligrams a day. It is only part of the treatment, and it depends on, there's so many complexities about pornography addiction and gambling and internet and video gaming and stuff like that. What I found is that most of the time, 50 milligrams a day isn't sufficient for most of those. And then there's usually some sort of augmentation I'm going to need to do. So if it's a pornography addiction patient, for example, often they will need an SSRI like Paxil that has a greater chance of lowering their libido, and then naltrexone to kind of combine those 2 together. If it's someone who has a sugar addiction and they can't manage their weight, sometimes they need naltrexone and Wellbutrin or some other weight loss thing, but It just depends on the patient, and usually they need higher doses. And then I always check their LFTs when they are on those higher doses.
And sometimes insurance companies want the higher dose.
Sometimes they do. Most of the time, if I do a prior auth, they will get it. Lately, I've had some people that I've had less and less problem getting those approved for some reason. I don't know, over the last year or two. Other questions? Oh, over here.
A different kind of question. I work in healthcare integration over in the West Park building. And now that are you considered an employee of Wasatch Mental Health?
I am contracted, so my private practice has a contract to provide services to Wasatch Behavioral for medication-assisted treatment.
So several of your clients have been coming through my office, and I know a lot of them have PTSD, almost all women, and some of them also have bipolar disorder, major depressive disorder.
Anxiety.
At what point do you decide whether you're going to continue to treat them yourself or refer them to a psychiatrist?
That's a great question. So if it's standard, I'm family medicine by trade, family medicine, and I did a fellowship in addiction, so I don't consider myself, a mental health specialist. But as a family medicine physician, I do feel qualified to treat mental health disorders. It seems like it's getting out of the normal routine standard realm, then I will usually recommend them to see someone like a psychiatrist. Because I wasn't trained to manage complex schizophrenia, bipolar, and things like that. Although I have found myself doing more and more of that over the years. Just, I think you get more comfortable doing what you're doing. So the more people that I see on medications, and then it's tough to get people in to see a psychiatrist. The demand is so high. So sometimes I will find myself trying to manage a little bit in the meantime until they get to the psychiatrist. And that has given me a little bit more experience doing some of those things.
Can you speak a little bit to how long an individual might stay on Suboxone or some of these other drugs, and then the tapering process?
Yeah, so that's actually one of the most common questions I get from patients is, how long do I need to be on this? That's the question. It's a really difficult question to answer because the data we have is not very encouraging about people coming off their medication. So they've done lots of good studies where patients have been on methadone for years and then they've tapered carefully so that they don't have withdrawal symptoms, and most of those people end up relapsing. Same thing that we're seeing with buprenorphine at this time. So the unhappy truth that I have to communicate to my patients is often that I don't know of any safe length of treatment where the risk of relapse isn't still very high. And I try to talk to them about other disease processes like chronic relapsing diseases like diabetes and high blood pressure. And I say, well, if you have high blood pressure, how long do you need to be on your medication? Or if you have seizure disorder, how long do you need to be on your medication? So it's not, there's no set time that I know of. I've never found any data that has said if they can go 15 years or 5 years, then their relapse risk is low. The relapse risk is always going to be high. So I try to encourage them to stay on it as long as they're willing. But obviously some patients are going to demand to come off of it. And then tapering with methadone is really tough because it's a full agonist, so they're going to have a lot of withdrawal symptoms. Vivitrol, there is no taper, they just stop. And with buprenorphine, it's a little easier to taper them. If they're on Suboxone, another reason we go on Suboxone for everyone is that it does not give them withdrawal symptoms, it automatically tapers them over the course of a few months. So that gives a window where they can just go down on their dose without having too much discomfort. Go ahead.
Hey, yeah. Can you talk a little bit about managing the side effects? I have a lot of people who struggle with, particularly the libido side effects on both antidepressants and methadone, but also the sedation.
Mm-hmm.
Those ones seem to be the big ones. They want, Adderall.
Okay.
Away.
There's going to be, and that's going to actually dovetail really well into the last part, which I want to make sure we have some time to go over, which is the medication policy that we have at Wasatch Behavioral. But yes, so the happy news about Suboxone or Suboxone is that most folks, if they're opiate use disorder, they've been exposed to a lot of opiates over the years. I mean, so much opiates for so much time. And since buprenorphine is a partial agonist, you're trading down on the side effect profile almost all the time because they've been using heroin or they've been using fentanyl, which are super strong full agonists that have way worse side effects than what you're going to give them. Okay? And so sexual side effects, sedation, nausea, those things tend to be a lot milder with any buprenorphine product than any actual opiate. However, sometimes it is an issue and you just have to do what you can. So if you go slowly, what I found if I titrate them upwards very slowly and I just watch for those side effects, I tend to have good success at minimizing them. So they'll say, oh, I'm too sleepy on this dose of 8 milligrams. I say, well, let's go down to 4 and then wait. And we wait. And then when they say, I'm not sleepy at all, then I'll bump it up again and see how they do. And as long as I go slowly, I don't tend to have a lot of those side effects. In a rare case, you'll have someone who just can't tolerate side effects. That's when I start talking to them about another alternative medication. Wellbutrin is one of the medications that I've seen has helped to counteract some of the sexual side effects and the drowsiness side effects from buprenorphine, if I ever have to do that. Naltrexone side effects are very minimal, especially if you do injectable Vivitrol. They don't tend to have a lot of side effects, and when they do, they tend to kind of go away on their own. People who do go above 50 milligrams on naltrexone do tend to have a little bit more difficulty. SSRI side effects of sexual dysfunction, I use Wellbutrin for that as well. And I don't use stimulants, but I'm in a substance use disorder treatment facility, so. Does that answer your question?
Yeah, no,
Okay.
Oh, I was just gonna ask one follow-up question on your Suboxone, the natural taper. I've had some patients that say, I need to get a little bit of buprenorphine to make it through, I'm starting to withdraw. How often have you noticed that?
That's usually, so on the first Suboxone injection, you don't get stable buprenorphine levels in everyone. You do for a lot of them. I'd say the majority will get stable levels. And then there's like 30 to 40% that won't. And so they'll come back and say, I'm withdrawing. Now, withdrawal is also very complex because withdrawal isn't always purely chemical. There is a lot of psychological withdrawal. They've done some really cool studies where you take people that are on a dose of methadone and then you taper them blindly so they don't know their dose has been tapered. And once they're on a 0 methadone, they still think they're on methadone for months. And then when you tell them, okay, you haven't been on methadone for months, they actually have bona fide withdrawal symptoms of vomiting and the goosebumps and the whole thing, right? So when they go off of their Suboxone and start on Suboxone, a lot of folks have difficulty with that transition because they're not taking something every day, and it's hard for them to make that transition. And they will say, I'm withdrawing. And I will encourage them that they'll be fine. Sometimes people have objective signs of withdrawal. I will give them a little bit of sublingual buprenorphine in the first few weeks, and then I will give them their next injection. And once I've done that, they usually do fine. Once they've had 2 to 3 injections, they don't need any supplemental buprenorphine because of the ceiling effect. Once you get up to that level, there is no additional benefit from getting any buprenorphine. We wanted to talk a little bit about, oh, I have to sign in. No, I don't want to sign in. Okay. So this, oh shoot, it's now making me, this is not a happy moment in front of everyone. I have to sign in. It's going to use up part of my time. Okay, so hopefully it won't make me sign in. So, oh shoot. I was so prepared that I passwords. Everyone loves their passwords, right? Okay, So at Wasatch, what is this doing? I need help. I need IT help. What's that? Because I just want to show you this policy and it keeps doing it. I don't know what it's doing this to me. Oh, I have to sign out of a different thing to sign. Okay. All right. Okay, so at Wasatch, we have a policy called the Potentially Habit-Forming Medication Policy. And all this, to distill, I'm going to go ahead and scroll through it, but to distill it down to the bottom line for those of you who are dominant trade people, and I need to tell you right up front, if they're in a substance use treatment program, they can't be on controlled substances, period. Like that's kind of what the policy is designed to do. It's designed to prevent problems that could ensue from people who are in a substance use treatment program with other people who have substance use program or substance use problems from creating issues. So Adderall, gabapentin, Lyrica, clonazepam, alprazolam, opiates, we don't allow those. THC, even if they have a card, all that stuff, okay? And so you're gonna see patients who are in our programs in the substance use side that are on the mental health side, and they will be told that they can't be on these things. And so this is just some examples of some of the things that our patients have been on or are on, and we have to kind of encourage them to discuss that either with their mental health provider or their mental health prescriber or their primary care prescriber, that they need to come off of these things in order to finish their mental health treatment, okay? We recognize that there are some exceptions to this. Very few, but there are some exceptions. Those exceptions we have to be very, very responsible when we make those exceptions because we have to think of not just the patient, but the entire treatment program. Because we have a lot of folks who get very triggered or very tempted when they are around people who are on substances that they personally have issues with. And so most of these substances are substances that aren't very often legitimately prescribed long-term without significant concerns anyway for anyone. But especially for our patients, they can't be on them while they're in treatment without some sort of other extenuating circumstances. So an example of an extenuating circumstance and an exception to the rule would be a person who has true neuropathy. They're followed by a neurologist. The neurologist is prescribing their Lyrica, and the neurologist we have a release of information with so we can communicate with them and so they can understand why we have concerns and that they can understand that we will validate whatever the prescriber decides to do. But the THC issue keeps coming up more and more lately. I have a card, I need to stay on my medical marijuana for my PTSD or for whatever it is they're staying on or wanting to stay on for, and we have to tell them, hey, you're in substance use treatment, you can't be on that. Most patients understand completely, and they'll say, okay, I get it. Every once in a while, we get someone who has very, very vocal feelings about our policy, and we just try to reassure them that this is not us singling them out, this is just us trying to do the best we can for our patients. But we wanted to make sure you guys knew, because a lot of times it affects you as you're seeing these patients, and they come to you like, oh, Dr. Bush is a horrible guy because he's making me come off my Adderall, or whatever, right? And it's more, we care about the patient, we want them to do well, we also want the program to succeed. So if you have any questions about this policy, now is a good time to ask them as well, or individually, you're welcome to email me anytime. Any questions about our policy?
So, like with the THC, and like, so the person that I was talking to about, when we did the liver intake for her, she is taking THC, but I am giving her Suboxone, but she's willing and going through the steps of going off of her alcohol. So as long as they're going off of these things, then it's okay, right?
Yes, so what we deliberately did not put in this policy is some specific time frame by which they have to be off of these things, because every case is going to be different. I have a patient who is on Adderall, clonazepam, alprazolam, Ambien, and I'm sure there's one more. I think gabapentin was the other one. And I'm not going to say, okay, the minute you walk in my office, you are going off of all of those things, right? Because do you think they're going to walk in my office the next time? So I sit down with them, I talk to them about the policy, I explain to them why it's important. I try to, listen to their concerns and be very empathetic about it and recognize which of these, so I usually will tell them which of these is the first one you want to work on. So, okay, I'll work on this one first. Okay, great, let's work on this one first. And then then after we've worked on that one and you feel confident, we can work on the next one. But eventually we will need to come off of them. I have a guy who's on Lyrica and he does not want to see me. This one, he didn't want to see me because he knew he was going to have to come off of his Lyrica. And the only time it really does come down to a really difficult problem is when they're in drug court and drug court mandates they come to our clinic. So we do Suboxone and Sublocade in our clinic. And if you go elsewhere, you can kind of dictate your own treatment, right? You can say, well, I don't want to go on Sublocade, I want to just stay on Suboxone. And so we don't do that in our clinic. So if drug court says you have to come see me, and I say the only way I'll continue you on buprenorphine is if you get Sublocade, then you are kind of stuck. You have to decide if you want to stay on Suboxone, right? Or you have to go back to the judge, the drug court judge, and try to convince him that you want to go to see another provider. But most other patients, I would just say, sometimes they will want to go see another provider because they don't want to follow this policy, or go to another program. So we work with them, is basically the bottom line. But we just wanted to make sure everybody's aware of the policy. Any other questions? I think we have like 1 minute left. I have sufficiently answered everyone's question and anticipated all the rest. Oh, one more.
Okay, I see Kratom on the list up there. I don't know much about Kratom. It was my understanding that it's an over-the-counter product. Is that still true?
Yes.
And it's listed as being addictive?
Yes.
And I've heard that it is addictive, but is it classified by our government as a controlled substance?
It is not. Where's another over-the-counter? I don't see alcohol on this list. Is alcohol on this list? Does anyone see it up there? Because these are prescriptions. Alcohol kind of falls into a similar category. It's over the counter. You can buy it. You don't need a prescription. It's legal, but we don't allow it. Kratom is a problem. I've had people come to me just for Kratom addiction problems. So I hope that answers your question. Okay. Yes, sir? So CBD is different. CBD is not a controlled substance, and if you can isolate CBD purely, then you're fine, because it's not going to be any issue. But it's impossible to separate CBD from THC in the plant, and therefore anybody who's on any CBD product, they need to know, and we need to educate them that your urine very well may come up positive for THC. The advertisers of CBD are very good at saying, we have 0 THC in our product. That's a lie. It's not possible. Even Epidiolex, which is an FDA-approved medicine we prescribe for seizures, and it's just CBD, has trace levels of THC in it because you just can't get rid of all of it. So when they take it and they get all, like whatever the placebo effect is from CBD that they're getting, they're starting to, if they take it regularly, they're building up THC in their system enough that eventually they'll probably start shedding it in their urine and it will come up positive. I have lots of patients who swear they have not touched THC and they're positive. And then when we look at it, it's kind of a low level, and we ask them about CBD, and they're like, well, yeah, I use CBD, but. So we just tell them, you can use CBD if you want to, just make sure you know. You won't be able to argue too much when your THC urine positive results show up, and then you get in trouble. So we usually tell them, it might be a good idea to stay away from it. Good question. Thank you so much for all your